Uh, Thank you very much, Dr. Khalid Asif, for finishing right in time. Next talk is on selecting the right coronary catheters guiders for success. And our speaker is Brigadier Asif Nadeem. May I request Brigadier Asif Nadeem. And again, request is to finish in 10 minutes, sir. Thank you.
So can I see my talk, please?
Day one.
Asif, yeah.
ठीक है?
Yeah, slides. So this talk was basically to be delivered by Major General Nasir Ahmed Samor, but due to some unavoidable circumstances, he couldn't come. So first balloon angioplasty was done by Gruensick in 1977, and the guide was a simple tube at that time. So far, the guides have moved a long way. So it is very essential for us to understand the structure, design, and fundamental characteristics of these guides. And the function of guiding catheters is, number one, contrast injection for opacification of the arteries, pressure measurement, passage of hardware and devices, and adequate support for delivery of intervention equipments. So this is the basic structure of a guide catheter. It is different from the normal diagnostic catheters because it has stainless steel inside the medium vessel. So starting from the inside to outside, it has got a silicone inside layer which is hydrophilic. And when we flush the catheter, the hydrophilic portion gets activated. The in-between is stainless steel and the outer layer is nylon-based. So anatomical considerations in guide selection is that the route of PCI is basically very, very important, that you are going radial or femoral. When you are going femoral, you increase the size of the guide by 0.5. Say, for example, if you are taking 3 in the radial, you'll go 3.5 in the femoral. Then the size of the ascending aorta, not the arch of the aorta, it is the ascending aorta basically. If the ascending aorta is dilated, you'll increase the size of your guide, say for example from 3 to 3.5 and from 3.5 to 4. If you are studying the native vessel, the grafts, the guide would be different. If you're studying the coronary graft, then it would be different because RC graft, as you have seen in the previous presentation, they are downsloping and you have to take a multi-purpose. Similarly, for Lima, you have to take the different guiding catheters. Location of the ostia, if they are anomalous, you have to take the guides accordingly. Tortuosity of the vessel is very important because you need more pushability, more force. In that case, you need more supporting guide like EBU or implants. Then the characteristics of the lesions, they matter because if you are dealing with this bifurcation, you would need more hardware and you would need a bigger guide like 7 French or something. And finally, it is operator dependent. So this is very important slide. It shows the size of the guide and the internal diameter. So it's easy to remember that if you are taking the 5 French guide, the internal diameter would be 1.5. If you're taking 6 French, the internal diameter would be 1.75. If you're taking 7 French, it would be 2. And if you're taking 8 French, it would be around 2.25. So normally we use 6 French guides, and 6 French guides are quite comfortable to use with thrombustor, and you can use with 1.25 rota ablation or 1.5 rota. But if you're thinking of bigger burr, then you have to move to the further size. 6 French are good for the IVUS, and 7 French, as I have told, is good for the bigger rota burr. So you can increase the guide support with the help of like guide extensions or buddy wires or extra support wires like BHWs or Grand Slams or anchoring balloon and a few other techniques. So normally we use these guides if we don't need so much of support. In the right coronary artery, we'll use Jitkin right, or in the left coronary artery, we'll use Jitkin left. If support is required, then we'll take implants left, implants right, hockey stick, or we can take XB3 or EBU. So this is what happens when you increase the size of the guide. If you're taking 6 French guide, it would occlude almost 40% of the ostium of the RCA, of the coronary artery, depending if the ostium is healthy and there is no spasm. If you are taking 7 French, it would occlude almost 60% of the ostium. And if you are taking 8 French, then it would almost occlude 80% of the ostium, leading to some ischemia during the procedure. So this is the lesion where the patient had ostial left main lesion. You don't want the guide to go deep inside, so you take Jitkin left in these cases. And the operator was quite comfortable in finishing, as you can see on the right-hand panel. EBU or extra backup guides are preferred because of extra support due to increased area of contact with the aortic wall. This is very important because these guides, they have extra contact with the opposite aortic valve. So you can see here that the Jitkin is having a minimum contact with the opposite aortic wall, but EBU is having more support against the opposite wall. And here it is a CTO case in which the operator was quite comfortable by using EBU, because you do not want to fight with the lesion and with the guide at the same time. You want to focus on the lesion, and if the guide support is not good, so your procedure would not be successful. So in the right side, if the artery is having normal origin, then Jitkin right is sufficient. But the problem with Jitkin right is that it does not go against the opposite wall of the aorta, and the support is not much. If you need support, you should use implants in this situation. So this is a lesion in which there is a simple lesion of the RCA, and the operator is quite comfortable. But in Shepherd Crook, you have to take a hockey stick or Arani or Akari or AL1. And if the lesion is downsloping, you can take multi-purpose. So these are various lesions which are manipulated by different guides. And as you can see that here, the lesion is downsloping. Rather, it is a CTO, and the operator is quite comfortable while doing this case with an implants guide. So grafts PCIs, they are slightly different because the right coronary artery graft, they are sloping downwards. You can take multipurpose. And the rest of the grafts, they can be studied with the help of Jitkin or implants. And for the internal memory artery, you can take internal memory grafts, guides. And this is a procedure in which multipurpose guide is used because this is RC graft, it is looking downwards. Again, a graft PCI in which appropriate guide is taken and successful PCI is done. So these are some standard safety techniques which you should adopt when you are doing an angioplasty. You should aspirate vigorously once you are in the aorta. Watch for the pressure curve. This is very important. This should be the reflex section of the operator. There should be a generous bleed back, and you should flush frequently to avoid stagnation of blood in the lumen of the guide. And you should constantly watching the catheter tip to avoid deep intubation or pressure damping. And during injections, keep the guide coaxial, and syringe should be pointing downwards. So in summary, these are the various guides which can help you in doing a successful PCI. And to conclude, I would say that guide catheter selection is the most important step when performing PCI. It is based on correct scientific understanding of the different guides available, the patient's anatomy and PCI route chosen, and there is no shortcut to the experience. Thank you very much.
Thank you very much. Now the next speaker is Major General Farhan Tayyab, and topic is coining guide wires, workhorse wires to specialty wires. May I welcome Major General Farhan Tayyab for his talk.